line. Thank you so much, everyone, for joining us for this HPBA Grand Rounds on the surgical management of pancreatitis, which is a great topic for us to hear about. Thank you, Dr. Hashmi, for presenting, and thank you, Aaron, for moderating this. I really appreciate everyone being on this call in December, right before the holidays. So without further ado, let me ask Dr. Baker to kick us off. Thank you.
Thank you so much, Dr. Jayaraja. We have a wonderful presentation that Dr. Hashmi has put together. And so without further ado, I'll let her go ahead and take it away.
All right, so I'm going to get started. All right, so for the outline, I'll be talking a little bit both about necrotizing pancreatitis and chronic pancreatitis, discussing about pancreatic debridement, the approach, the timing, talking about step-up approach, transgastric necrosectomy, and then some slides on open pancreatic debridement as well. And then delving into chronic pancreatitis, talking about different surgical options, and then if time allows, something about islet cell transplantation as well. So before I start talking about surgical management, I just want to emphasize that management of pancreatitis is really a multidisciplinary team effort. So surgery, interventional radiologists, and gastroenterologists essentially work together as a team. Nutrition intensivists, those they also form part of this team that help us take care of these patients. And then secondly, it's really a heterogeneous disease process. There is no one-size-fit-all model for this. So one approach might be good for one patient, but ultimately may require either a combination or a different approach for a different patient. So, necrotizing pancreatitis essentially, or pancreatitis on its own, is also a dynamic process. There are different phases of the disease. The early phase has the highest mortality, and that's secondary to multi-system organ failure, which leads us, into essentially after about 3 to 4 weeks into sort of a quiet phase for a week or so, and then there is a second peak of mortality, which is secondary to secondary infection. So talking about natural history of pancreatic fluid collections, about 15 to 20% of patients with acute pancreatitis will have severe acute pancreatitis, which will be characterized by organ failure, and then they'll develop pancreatic or peripancreatic necrosis. 10 to 15% of these will resolve with time and will not require any intervention. A percentage of them will become infected and will require some intervention. This could be in the form of either antibiotic treatment, percutaneous drainage, or operative management. And then there's a subset that will have persisting collections, and then we have to really decide basis on the symptomatic, essentially, presentation of these patients. Because if these patients are not symptomatic, they can be safely observed. However, if they are symptomatic, which may include anything from having, persistent low-grade fevers or inability to eat or tolerate enteral nutrition, then an intervention should be considered. So intervention historically was essentially just composed of surgery, essentially gigantic laparotomies. The patients were taken back and forth to the operating room for stage or planned debridements. There have been reports from centers, from Mayo essentially for the zipper technique where the patients were taken back and forth to the operating room, laparoscopy where the packing was changed every few days. And not surprisingly, this technique was essentially led to high mortality and perioperative morbidity, including bowel and pancreatic fistulas for these patients. And so more recently, in the last decade or so, there has been a more contemporary approach, which is the step-up approach, which really starts with percutaneous drain placement and then leads to subsequent steps, which could consist of transgastric necrosectomy that could either be endoscopic or surgical. And then retroperitoneal essentially approach, which either could be video assisted or sinus tract necrosectomy, which is more common in the UK. And then, open pancreatic debridement, I think, still has a limited role to play in some selected patients. And then any combination of this treatment could be applicable to a patient. Again, like I had mentioned before, there's no one size fit all. No single technique is going to be applicable to all these patients. So the goals of intervention really is, the first and foremost should be really to, none of these patients should require really any early intervention. And the reason is that early intervention, it has very high perioperative morbidity and mortality, unless there are some complications. And the most common complication, which will sort of force us for an early intervention, will be visceral ischemia of the gallbladder or the colon itself. And I'll talk about it a little bit later as well. The other goals will be to control the infection, evacuate necrotic debris, drain the pancreatic fistula, and prevent recurrence, and get these patients really to a physiologic better place. So when will surgery be really indicated for necrotizing pancreatitis? Now, biliary pancreatitis, as we all know, that removing the gallbladder would subsequently essentially allow no further episodes of pancreatitis, or 1/3 of these patients that continue to have these gallbladders will have subsequent episodes, but you can certainly delay it. There is no hurry to remove the gallbladder for these patients, especially if somebody who's had an ERCP and a sphincterotomy, this risk comes down to 3%, and these patients can certainly be delayed for if they're going for another intervention for a cholecystectomy. Visceral ischemia, like I mentioned, both for a colon or gallbladder, and really what happens is that the inflammation causes the mesenteric vessel thrombosis, or even small veins to thrombose, and that can lead to ischemia of the colon, the gallbladder. So if the patient had been doing okay and then all of a sudden is not doing okay, these two things should be considered. Bleeding is rare now, given the excellent essentially interventional radiology. That's the route you would take for these patients, but rarely we might be pushed to do surgery for bleeding as well. And then obviously if there's failure of any endoscopic management, or a selected number of patients that have like extensive or multiple field necrosis that's either extending into the paracolic gutters or going down into the root of the small bowel mesentery, they might be served best with surgical intervention. So one important thing that I wanted to talk about is, I think especially if we were talking to other services, that do take care of pancreatitis patients, and for, if patients have been imaged and they just look, see a collection and there's a gas within a collection, they will always straight away go ahead and, essentially want them drained. But gas within a collection is not always an indication for an intervention. So if the patient is not symptomatic, is not septic or any other symptoms, these patients can be watched as well.
Right, so could I have you pause it for just a second?
Yes.
So, one of the things that you didn't mention on the previous slide was just talking about patients who are presenting in severe acute pancreatitis who also have a component of necrotizing pancreatitis. We see a fair amount of this, and we also see a fair amount of patients who present with abdominal compartment syndrome. And so in those patients with abdominal compartment syndrome, we are sometimes forced to do a laparotomy on the patient early on in the disease process before there's been kind of the demarcation of the pancreatitis. And so what I want to do is I want to just kind of turn this question over, and we'll turn it over to University of Louisville, and just ask, in a patient that presents with severe acute pancreatitis and abdominal compartment syndrome early in the disease process, so the upslope of that initial curve, or a few days or a week into their disease, would you do something to attempt to treat their pancreatitis at the same time in terms of any operative intervention specifically for pancreatitis? So if Connor or Mark want to make a comment.
Yeah, I wouldn't. I would treat the abdominal compartment syndrome. Obviously, that's a major priority there, and it probably wouldn't violate the retroperitoneum if it wasn't infected at that point.
Okay, just to get another opinion, can we have the folks over at Toronto General, any thoughts on the setting of abdominal compartment syndrome, and whether or not you would do anything in that type of a setting for patients with severe acute pancreatitis in terms of plaque?
Hi, this is Chris Schubert here. I have to be honest, in our practice here, we rarely see pancreatitis or deal with these patients, fortunately or unfortunately. But to answer your question, I agree with the previous comment. I would deal with their abdominal compartment syndrome, but in an acute setting, I don't know that I would go, stirring up trouble. I would just wait and see how it, resolves with time.
Okay. All right. So Leela, why don't you keep going with your presentation?
So I'll just, on that point, even if a patient is, like I said, for early intervention, if the patient is going to the operating room for colon or gallbladder ischemia, you should just leave the, pancreas as it is. Take care of the acute problem, and that can be dealt at a later point, so don't stir more trouble essentially. And as for compartment syndrome, honestly, the more recent data essentially with the excellent ICU care, because previously all these patients that will come in with acute pancreatitis will just keep on getting fluids for resuscitation, and so the incidence of compartment syndrome was higher for these patients, and over time, if you see, that has certainly gone down. So for the more recent reports, the incidence is much lower for compartment syndrome for these patients as well. All right, so next, moving on. So distribution of necrosis can also dictate the intervention technique. So if essentially the necrosis is confined to lesser sac, there is a disconnected tail. So the transgastric approach that I'm going to discuss a little bit later may be the preferable approach. However, if this necrosum is extending to the paracolic gutter, may need to take a different approach. And if there's multiple field necrosis, extending essentially both paracolic gutters to the root of the mesentery, then this might need to be tackled differently. And like I said, possibly even, open pancreatic debridement may not be the worst case scenario in this situation. So patient selection is, important. Like, how do you select which patient is going to end up getting what intervention? It depends a lot on, like I said, necrosis distribution, the patient physiology. Can they tolerate a big intervention, or is it something that you really want to go up, sort of go in a systematic step-up approach? How much of the necrosum is solid? Is it something that a drain by the interventional radiology guys can be taken care of or not? How much parenchyma is involved? How much infection there is, and then local expertise at your center. So if you don't have that much expertise in the GI folks, then endoscopic management may not be an option, and you might be forced to do a surgical intervention rather than going that route. So for the step-up approach, percutaneous drain is really the first step. In studies, it has been shown that about 30% of the patients that will be treated with percutaneous drain may not ultimately require any more intervention, and this is all that they may require. But like I said, the necrosum may actually be just not liquid and solid, and so the drains may not be helpful for these patients, as shown in these pictures here. So the question then becomes, is it, really when you put in a percutaneous drain, when is, really the time for the step up? Like, when do you move on to the next step? And honestly, there is no clear-cut guidelines. You just have to essentially see how the patient is progressing, and then sort of decide. So this is a point of debate for a lot of papers that discuss about evolving treatment for necrotizing pancreatitis, as to there is no real guidelines as to when do you move on to the next step in the treatment. So the retroperitoneal step-up approach essentially consists of, a couple of things. It could be a video-assisted retroperitoneal debridement, which is, VARDs. Essentially, this is very popular its use is very popular by the Dutch group. Then there's minimally invasive retroperitoneal necrosectomy, also the sinus tract necrosectomy, which is mostly used in UK, and then the last option is an open lateral approach as well. Obviously, open lateral approach, is associated with more morbidity in terms of enteric fistulas, bleeding, or even colonic necrosis. So this is a picture that's really showing how, you should have a drain in essentially the left side, and then, how a subcostal incision can be made, or you can just use the drain as essentially guide, and then go using a nephroscope or a laparoscope, and then, visible necrosis can actually be removed using this. And this is another picture showing the VAR technique that has been described by the Dutch group. Care should be taken that when you are removing the necrosum, it should only be the mobile necrosum that you should remove. Don't force your forceps or whatever instrument you're using, because again, there is like portal vein may be there, and you might not know, and you might actually even pull up the anterior wall of the portal vein. So you have to be just really careful that only the loosely adherent pieces of the necrosis are removed. So this is a recent data, essentially 2 RCTs that were published in this year, looking at endoscopic and minimally invasive surgical step-up approach. First one is the Miser trial, and the second one is the tension trial. The Miser trial, I'll just talk about that one first, essentially. About 30 patients in each arm. One was, the first arm was endoscopic, and it was a heterogeneous, essentially, approach. So depended on what the gastroenterologist wanted, they used both plastic or metal stents, depending on what they felt comfortable. And it was same for the surgical arm as well. It consisted of both either VARDs or lap cyst gastrostomy. Again, it depended on what kind of distribution the necrosis was in, what kind of procedure the surgeons were preferable or comfortable with. So the one thing, the morbidity obviously was much higher in the surgical group compared to the endoscopic group, but what they did was also included the fistula, the pancreatic fistula, which for the most part in the surgical group meant the drains that they had left after the surgical intervention, and that's what was counted in here. If you remove taking that into account as one of the composite endpoints, then the endpoints essentially were similar, which was the case for the tension trial as well. One of the other things was that for the Miser trial, even though they took sicker patients in, some of the interventions also happened less than 4 weeks before, after the essentially onset of pancreatitis, but their mortality rates for some reason are very low in single figures, which I hadn't seen in any other trials or case series from other institutions. So that was something surprising. I don't know if anybody else has read these trials and has any comments about those 2 things. Yes.
Go ahead.
Sorry.
Did someone have a comment?
Okay, I thought somebody was saying something. Next is.
Pause for 1 second. I just wanted to. I'm going to throw a question out to the group, and just in terms of the step-up approach, the question I would ask is in patients who are morbidly obese, where particularly the distance of their abdominal wall can sometimes present additional challenges if you're trying to do a retroperitoneal debridement, through smaller incisions. And so I just wanted to ask if anyone has any other technical aspects of that procedure that may help to increase your success with doing that type of a minimally invasive approach or pancreatic debridement. So why don't we turn it over to Washu? What is your all's experience using this step-up approach or retroperitoneal debridement for small incisions?
Yeah, so we would reserve that technique for the left side. A lot of the other spaces are accessible endoscopically increasingly. When we have people who are obese, then often we'll start by getting the interventional radiologist to put a drain in there, and we subscribe to the theory of waiting as long as possible, as much as the physiology allows. So then we'll progressively upsize that drain and then put in a laparoscope. And then it's little things like the patient positioning, just to get it in a dependent spot and being conservative and doing it repeatedly if necessary.
Okay, thank you. Let's we'll turn to one other site and just get any other comments. How about Methodist Dallas? Do you guys have any other thoughts of how to do the step-up approach from minimally invasive fashion, using drain guidance or otherwise?
Yes, so Terence, you want to talk about this? This is step-up approach. Any technical?
Oh yes, hi, I'm Terence. So I love this procedure. I personally have had the chance to do it thrice in residency, once here as well. Again, left side abscesses, which are infrasplenic, close to the subcutaneous area, and has a drain in it, which we've upsized. In my mind, the indication for such a procedure is non-progression. If the patient does not get better over a course of a few days and our interventions are failing, that's when I start to think about debriding this. Typically, I pass a cut right on top of the drain, make a subcutaneous space as big as about 1.5 to 2 centimeters, and then use a long 15mm thoracic port, and just one port. We put it straight into the cavity. Usually you should see pus come out straight away, and then we use a 5.0 or 5.30 camera along with one other instrument, and do a procedure very similar to a pediatric single-site appendectomy, where we're moving the camera and the instrument at the same time and debriding as gently as possible. And it turns out really well, and we leave drains afterwards into the same space.
So those are kind of a couple of our tips over here. The only other thing I just wanted to comment on was, Salila, we in our experience would absolutely drain something with air in it, like what you've got over there. I know there's some controversy around that. We probably would be uncomfortable sitting on that. The second thing, Aaron, is we've seen very little in the way of compartment syndrome with sort of resuscitation. I know David and I have discussions about this all the time, but it's not that common that we have to decompress somebody for compartment syndrome. Those are my only two comments.
Thank you, Rohan. No, I appreciate that as well. I'm not sure if we just see a lot of it here, but it's not uncommon that we see compartment syndrome, but it does make me think about that in terms of our ongoing critical care resuscitations and opportunities for us to do things differently as well. And then the other comment I just would add to the descriptions that people have had thus far, sometimes when we're doing a step-up approach, we'll actually place two drains, one from an anterior position and one from the lateral position, and then use to guide them into that retroperitoneal space, and then we can have a camera via one port and our instrument using to do the debridement through the other port, so that you're kind of looking at it from a right angle. And that's another way that we will sometimes do the debridement as well, just being able to have two ports in place. And we also leave drains in place as well, similar to you guys. All right, why don't we turn it back over to you, Salila?
Okay. So I'll move on to the transgastric necrosectomy. This is essentially one-stage procedure with a durable internal drainage of any persistent pancreatic leaks. The one thing you have to be careful about is when you're considering step-up approach, and if there is a wall duct necrosis that you think will ultimately be amenable to transgastric necrosectomy, just be careful about how you ask the interventional radiology to put in your drains, because if it's not contained anymore, the necrosum, then you won't be able to do this successfully in the future. So there have been instances where we've actually asked them to go and put the drains for us, like transgastric, into that collection, just to get the patient a little better, so that we can take that patient later for a surgical transgastric necrosectomy. These can be done both endoscopically or surgically, and then surgically both, with an open or a laparoscopic approach. Just for the endoscopic approach, they do put in axial stents when they do this, but again, like I showed the pictures of those necrosum, if it is going to be a solid necrosum, there's going to be, difficulty with that necrosum being essentially decompressed, and then you have to consider if this patient will be more suitable for like a surgical necrosectomy. So essentially the open transgastric necrosectomy can be done with a small upper midline laparotomy. An anterior gastrotomy is made between two small sutures. We usually use for a PDS here, and then you can either palpate where the necrosum is going to be, or you can also use intraoperative ultrasound and essentially direct where you're going to make the posterior gastrotomy, and essentially create a common channel between the wall duct necrosis and the posterior gastric wall. And then, we use a running locked suture, essentially on a large needle, like a 3/0 suture on an MH needle. And that's really because this will also help later in hemostasis. So one or two of the times where we haven't done that, we've had some issues with hemostasis as well. Alternatively, this can be done with a stapler as well. And once this is done, you remove the necrosum. And again, like I had mentioned, very gentle. You don't want to see blood coming out of the portal vein. And so, you can do some aggressive flushing with saline, but when you're using forceps or any instruments, you just want to be removing just the mobile, essentially part of the necrosum. And then the anterior wall of the stomach is closed. Typically drains are not left, but if you really feel like there is some like undrained pocket or something that is not really or is different about the case, then some drains can be left depending on the surgeon's preference. So like I said, this can be performed laparoscopically as well, and the main approach that has been described is the intragastric approach, where the stomach is actually insufflated with an endoscope. They're like two radially dilating trocars that are placed into the stomach, and then you can use again the intraoperative ultrasound, or you should be able to even predict with your preoperative imaging where the necrosum is going to be, and then make a posterior gastrotomy and essentially do the same steps. So this is how it's going to look like on the patient. This is a necrosum, and then you can just put it down the pylorus. You don't even have to remove the necrosum, and ultimately it'll be passed out. You can do this using, if you don't want to use the intragastric approach, you can just do access to the peritoneal cavity, use your intraoperative ultrasound, the same thing, make an anterior gastrotomy, make a posterior gastrotomy, just take a bag and remove all this necrosum put that into a bag, and then, remove the bag like you would do for a lap pulley essentially, and then close the anterior wall of the stomach, either with sutures or staplers, whatever you prefer.
So Leah, how do you decide between which technique to use, meaning open versus laparoscopic versus endoscopic gastrostomy? And how do you guide the patients as to which technique is most appropriate?
Yeah, so essentially, if it's going to be like a large cavity with a lot of necrosum, so, if I see the diameter being somewhere close to 15 or 20 centimeters, then that will be somebody who would be more amenable for an open approach. The other thing what was I going to say? We at a center as Calgary over here, we will do mostly open. That being said, it's not like we've never done laparoscopic, but mostly we will do open necrosectomies. And then I forget, sorry, there was one other thing that you had asked me.
Mainly just about how you decide, which patients are most appropriate for which of the procedures, and if what goes into that decision-making process.
Okay.
Is it in the lesser sac, or is it?
Yeah, and then the other thing, sorry, I remember what I was going to say. It's also the necrosum. So if it looks like it's going to be, mostly solid with not, you can't. If I will have difficulty doing that laparoscopically, then I would obviously opt for an open one where I think I can do a much better job. If it's a larger cavity, like I said, then that would be another indication. If it's going more to like extending more into paracolic gutters and not just behind the stomach as well, that will be another consideration for an open transgastric necrosectomy.
Okay, thank you. Please go on.
So this is essentially a paper that was published last year by 3 institutions here in Calgary, Indiana, and Stanford, and they looked at patient outcomes who had undergone surgical transgastric necrosectomy. Most of these patients were, males. The etiology of pancreatitis most commonly was biliary pancreatitis. The mean wall-off necrosis diameter was about 14 centimeters. Most of the procedures that was performed was done open, and there was about 23% that were done with the laparoscopic approach as well. So this is like the overall outcomes. Postoperative morbidity, about 11% had intra-abdominal infection, only 6% had some bleeding, 4% with pancreatic fistula, and 2% required some reoperation. Mortality was at 2%. Amazingly, 92% of these patients were able to go home, and about 91% of these patients had complete symptom resolution with just one single stage procedure. So I think this was, remarkable, essentially overall outcomes looking at these patients. But again, you have to select, which patients are the perfect candidates to undergo this procedure, and it's not like a one-size-fits-all for these patients. So a few words about, open surgical necrosectomy. Again, it's a single procedure. It is safe in the sense that, if a patient has varices, it could be safer. Obviously, there's still a chance that you could run into bleeding. And then this is sort of a gold standard that we compare everything to, because this was the only thing that was present for many years. Preoperative imaging and then again, intraoperative ultrasound can be helpful. The SME and portal vein confluence will again be a danger zone. There are going to be adhesions between small bowel and transverse mesocolon that you have to be very meticulous about taking down. The gastrocolic ligament is going to be foreshortened, and so you have to be aware about that as well. Sometimes it's better to take the paracolic approach, whereby mobilizing both the flexures may be helpful. And again, like I said, removing only the mobile necrosis, taking some cultures, and then leaving drains, and then plus minus a feeding tube, depending on the center preference as to how you think the patient is going to do afterwards as well. So the challenge, again, is the patient selection. Like I said, if it's very extensive, extending into multi-fields or going down both the paracolic gutters, maybe those patients are the, better candidates for doing this. And again, the question, again, like for everything is, when do you intervene and commit somebody to an open debridement compared to all the other rest of the steps that you're going to undergo with a step-up approach? Any questions or comments before I head on to the chronic pancreatitis part?
Any comments from the others?
Yeah, I just wanted to jump in with a quick comment because I may be one of the few people on this conference that's old enough to remember the days where patients were taken to the operating room acutely with pancreatitis. And just to state that what you've gone over, Dr. Hashmi, is truly amazing evolution, because in the 80s and 90s, the dictum was to take these patients straight to the operating room. And that was a disaster. It used to be a bilateral subcostal incision, sometimes with direct packing of the retroperitoneum, with tacking of the stomach to the upper flap and the colon to the inferior flap as you did that. And unfortunately, I participated in literally packing the retroperitoneum at the bedside with frequent bleeds here, there, and everywhere. Thankfully, that has changed. I think one question I would just like to ask you is there any role for FNA of pancreatic necrosis? And because that was a very hot topic at one time. What are your thoughts with regard to that?
Yeah, so I would, personally shy away from that, because honestly, if there's a chance of you introducing infection into something that might just be sterile, so you don't want to do that and make it worse for the patient. Your antibiotic management and everything is going to be guided by the clinical picture of the patient anyway, so I don't think that's really going to give you much, clinical information that's going to be helpful in the overall management of the patient. So that's why I'm away from doing that.
So are there any other comments from any of the sites that like FNA? Medical College of Wisconsin, are you guys fans?
Sorry, this is
Ron.
We don't do that. We don't FNA it anymore. I think there had been data in the past about the risk of actually infecting the retroperitoneum.
Any other comments?
Oh, hi, this is Mike Jacobs. We base the need for base the need for FNA on the patient's clinical condition, and sometimes we will still do it. My comment is actually when you're doing a transgastric, or even if it's not transgastric, any kind of necrosectomy, you really have to also be careful about the risk of pseudoaneurysm of the SMA, even possibly the renal artery if you're deep enough, and then specifically the splenic artery. So that can happen. So just you don't have to clean the slough to perfectly clean, especially if you're doing transgastric, because you already have a communication. You just need to get the loose slough off so that you can send cultures. And almost 100% of these patients will have some degree of bacterial or fungal infection when you do it. So just don't over debride it. Be a little bit careful there.
Back to you, Erin.
All right, thank you so much. We'll let you go ahead and move on to chronic pancreatitis treatments, Leila.
Okay, all right. So surgery for chronic pancreatitis indications, unsuccessful endoscopic management, intractable pain, symptomatic local complications, or, suspicion of malignancy. So this will dictate essentially a surgical intervention for a patient with chronic pancreatitis. Looking at endoscopic versus surgical management of chronic pancreatitis, surgery, there have been multiple studies that have shown that surgery is superior to endoscopy in terms of pain control, less procedures required by these patients, being cost effective. And one of the studies actually even showed that the greater the number of endoscopic interventions were done for a patient, that was actually a poor predictor of the outcome in, eventually for chronic pancreatitis. So these are the two trials that I have on here. One, had only 72 patients and one had 39 patients. They looked at both endoscopic and surgical management of chronic pancreatitis. And again, the verdict was the same, that patients who underwent surgery, there were more of them that were pain-free, 34% versus 15%. And for the second, it was 80% versus 38%. They had better improvement in quality of life. They required fewer procedures, and they had similar length of stay and morbidity and pancreatic function. So how is, how do you decide which patient is going to get what procedure is essentially based on how the pancreatic duct looks like. If it is a dilated pancreatic duct, which would be defined as something over than 6 to 7 millimeters, then mostly a drainage procedure, either, a lateral pancreaticojejunostomy or Puster procedure would be applicable. But if there, in addition to the ducts being dilated, there is some disease in the head of the pancreas, or it's, there's fibrosis, then doing a Frey procedure, which includes coring out the head of the pancreas in addition to a lateral pancreaticojejunostomy will be the procedure of choice. However, if the pancreatic duct is not dilated, then it depends which part of the pancreas has, disease. If it's a head dominant disease, then doing a pancreaticoduodenectomy or a duodenum-preserving pancreatic head resection. If it's a tail dominant, then distal pancreatectomy. And if it's a diffuse parenchymal involvement, then thinking about total pancreatectomy will essentially be the options. So like I had said, a dilated pancreatic duct may benefit from a drainage procedure, a Puster or limited resection of the head with Frey's procedure. So lateral pancreaticojejunostomy basically entails opening the pancreatic duct anteriorly along its length, medially to the level of the GDA and laterally into, if there have been any strictures before, make sure that you involve them. Remove all the intrapancreatic ductal stones if they were present, and then sewing a Roux-en-Y jejunal limb for drainage. The success rate of this procedure seemed to, especially with minimally invasive techniques, seems to increase as the size of the pancreatic duct increases. And I'll show another table a little bit later, comparing the morbidity, mortality, and also the pain relief for all these procedures combined together. So the Frey procedure that I had mentioned essentially involves coring out the head as well, in addition to doing the same lateral pancreaticojejunostomy. And this helps, essentially with pain because of all the neural component that is present secondary to fibrosis in the head of the pancreas. For the non-dilated duct, like I'd mentioned, it really depends on where the disease is present. If it's the head, then doing the Pancreaticoduodenectomy or Duodenal-Preserving pancreatic head resection. If it's tail dominant, then distal pancreatectomy, and if it's diffuse, then full pancreatectomy. There haven't been that many studies looking at, classic versus pylorus preserving for pancreatitis. Essentially, depending on what the patient or surgeon preference is, either can be done when, and they have been equal in outcomes essentially. The duodenum-preserving pancreatic head resection is essentially the Beeger procedure that I'll show a picture for here. So, this involves essentially dissection of the pancreas at the level of the portal vein, and then not only removing, coring out the head of the pancreas, but also removing part of the pancreas over here. And then instead of one anastomosis, this involves two anastomoses, one to the pancreatic tail and to the other remnant of the pancreas that is left essentially on the duodenum. So, is there any difference?
And I just want. Can you pause for 1 second and just go back to this slide? And I'm just curious if any of the other sites have much experience with doing this type of a procedure, of the duodenal-preserving pancreatic head resection, and how do you best choose the patient for this type of a procedure? Any of the other sites that are doing this very often? Maybe not.
Can you hear us?
Yes.
Oh. Now, this is Virginia Mason. We've been trying to connect for a little while, but we tend to be more of a Frey and Cousteau shop. These beggars and duodenal preserving procedures are certainly, niche type of procedures, but we have pretty good outcomes with our approach.
Thank you. And just one other question. I'm going to throw it out to one of the fellows. Why don't we go ahead and we'll call on the folks at Mayo. And I just want to ask, when you're evaluating patients for chronic pancreatitis who have undergone multiple endoscopic procedures, and I mean pancreatic stent placements, dilation of strictures, etc., how do you guide that in terms of helping to guide patients regarding whether or not to pursue surgical intervention if the patient has relief of symptoms with endoscopic interventions versus if they do not have relief of symptoms with endoscopic intervention? So what is your thought about that in terms of whether or not they should proceed with surgery for chronic pancreatitis like a Cousteau procedure?
Yeah, so I was just we were muted, but I was gonna say we have some duodenal, we have some beggars around Dr. Starr, who some people will remember seeing on the circuit, like to do the odd beggar, and it's a pattern of disease where if you have head dominant fibrosis where sometimes mobilizing the head of the pancreas off of the SMB and off of the retroperitoneum can be quite treacherous. So that's an option where the beggar can be quite successful. In terms of, you're talking about whether patients benefit from stenting and how that determines your access to surgery. There's two components there. There's the pancreatic ductal hypertension, and then there's the local inflammatory component to that. All the endoscopist can do is decompress the pancreatic duct, and that will tell you whether a decompressive procedure like a Cousteau, or as they used to teach us in Toronto, a Partington Rochelle is actually what it's supposed to be called, is actually going to be a reasonable approach. But actually, if they've got calcific or fibrotic pancreatitis, particularly if it's isolated to a portion of the gland, then a resective procedure is going to be beneficial.
Great, thank you very much. I'll let you go ahead and keep going, Salila, please.
So one trial that I wanted to mention was the CROPAC trial. So essentially looking at long-term outcomes of patients with chronic pancreatitis. One group was allocated to undergo Pancreaticoduodenectomy, and the other one was allocated to undergo duodenum-preserving pancreatic head resection. Ultimately there were only 88 and 84 patients who completed the trial, but at 24 months, there was no difference in in quality of life scores, mortality or morbidity. The only difference was that the operative time was shorter for duodenal-preserving pancreatic head resection. It was 4.7 hours versus 5.3 hours. However, readmission secondary to chronic pancreatitis, or readmission for chronic pancreatitis, was less frequently seen for patients who underwent pancreaticoduodenectomy. It was 27% versus 11% for the other group. So tail dominant disease, like I said, distal pancreatectomy can be an option. Postoperative pancreatic fistula rates are, as high as about 30 to 40%, and postoperative exocrine failure is described anywhere from 8 to 45% on in the different series that have been published. Diffuse disease, especially genetic pancreatitis or salvage pancreatectomy, essentially for not one area of pancreas being involved, but just overall the whole pancreas. Total pancreatectomy should be a consideration. The only other thing that, you can either do a retrocolic gastrojejunostomy or anticolic. But the rest of the, doing an HJ and then a GJ essentially. Pain relief rates have been described as high as 72 to 100%. Similar perioperative outcomes compared to other major pancreatic resections. However, all these patients will develop brittle diabetes. 15 to 75% of these patients will experience severe problems with diabetic control, and it's not only insulin dependence, but essentially secondary to some islet cells being removed, they also have an unpredictable response to exogenous insulin, and they may develop like morbid hypoglycemic unawareness. So that is one of the things to be wary about, and therefore this is a table that I put forward for all these procedures that I just described. Pain relief is anywhere, essentially on essentially order of greater than 50%, but the morbidity is real for all these procedures and must be considered, and then especially mortality for some of the procedures, especially the total pancreatectomy. The insulin dependence that I talked about, how can we tackle that is, with islet cell autotransplantation. Pain relief, again, similar pain relief, morbidity rate and mortality rate is similar, but significant improved quality of life with about 10 to 40% of these patients who will have insulin independence. But one of the things is how durable are these islet cells going to be in the long term? So there have been two studies. One looked at the 5-year essentially durability, and one looked at the 10-year durability. And the narcotic independence rate was for 5-year one was 73%, and insulin independence rate was still at about 30%. And for the 10 years, still the pain relief was 80 to 90% at 10 and 15 years, and then insulin independence was 20%. So the only thing, that is essentially interesting is because all these patients who have had chronic pancreatitis are not going to have that much of islet essentially cells, and transplanting greater than 4,000 equivalent per kg of these islet cells is like a strong predictor for insulin independence, which you might essentially not be able to achieve for most of these patients. So we have to keep that in mind. So in conclusion, just the highlights from the talk: management of pancreatitis requires a truly multidisciplinary approach. The surgeons have to be involved while talking to the interventional radiologists and with the gastroenterologist, also talking to the ICU folks, the intensivists, and the nutritional support staff. There's no one-size-fit-all treatment for necrotizing pancreatitis. If possible, should delay the debridement for more than 4 weeks. High morbidity and mortality if procedures are done before that. Open pancreatic necrosectomy may have a role in selected patients. Surgical management of chronic pancreatitis is probably better in the long term than endoscopic approach. Most surgical procedures will provide pain relief, but we need to consider the high morbidity and even mortality for some of the procedures. So key takeaways, inflammation, if there's a mass in the head of the pancreas, essentially after pancreatitis, think about doing a Whipple procedure or a Beeger. If there is groove pancreatitis, think about pancreatic divism for those patients. If there is dilated PD, Pusto may be an option, but if there is some fibrosis in the head of the pancreas, then Frey may be a more appropriate. And sometimes Frey can also address some strictures in the body and the tail as well, because you're opening the pancreatic duct all the way essentially. And that is all I could do in an hour for a topic like pancreatitis. Happy to take any questions or comments.
It's a great presentation, Salila. We thank you very much. If there's any other comments from any other sites, we're happy to take those now. Well, with that, we'll just wrap up. And again, thank you everyone for joining us today for the conference. And I think Phil is our next is in January. Is that correct?
Yes. Next will be January 8th. Virginia Mason will be moderating, and Methodist Dallas will be presenting. Everybody have happy holidays, and thanks so much for joining us.
Thank you.
Thank you. Have a nice holiday.
These fuckers at Union create this disaster.